Good.
And we're live.
All right, everyone, you're welcome to our webinar today on vaccine equity. We have Marlise, Richter here. She's here. We also hoping that we might have, I think we're getting an apology from the Director General of the NCDC. That's the Nigerian Center for Disease and Control. We're getting an apology from him, so we might not be able to have him. But I'm certain that we're going to have a great conversation here on vaccine equity across Africa, and we also have a reflection for someone who has dived into the topic in a significant way. Please put your names and where you're calling, or where you're watching us, where you're joining us from on the box. So, which is the chat. Then we also have a Q&A box, which directly tells us, which directly goes to the part around question and answer for Marlise or myself, or for anyone that is in here. That's so Marlise Richter is our speaker for today. And before we begin, I would just want to do a little bit of introduction about what exactly we're trying to have today. Our focus today is on vaccine equity, and this is in part of our Account for COVID webinar. So in 2020, 7 organizations, which is Accountability Lab, Afro Leadership, Budget, Code, and Follow the Money, Greco, Global Integrity and Public Service Accountability Monitor, called PSAM. They came together to collaborate on an initiative called Account for COVID that promotes and advocates for greater accountability, civic inclusion, and transparency in the COVID-19 Relief Fund and other allied expenses. So we've had sessions on the COVID situation. We've had a conversation on fiscal governance and transparency. We've had conversations on inclusion and social impact of the whole COVID-19 crisis. So that's between June and November. This is the 4th webinar that we are having and I'll put a microsite so you can, for our previous editions, you can visit our microsite, which is civicarchive.org/account for COVID. We should have a main site very, very soon, where we all chronicle all our conversations. I'll put the link in the chat box. So please don't forget to tell us where you're coming from. I'll put that in the chat box where you can find our microsite, civicarchive.org/account for COVID. I will go straight into why we are here today in some sort of way. We are aware that COVID-19 has killed more than 2 million people, and experts are saying that we all have to get vaccinated after months of social distancing and wearing of masks. Then we also understand that the development of COVID-19 is lopsided. The science and the technology backing most of these vaccines has resided more on the side of developed countries. So we hear vaccines also from the US, from China, from US, from Russia, from the UK, and the rest of that. And we are afraid that in a multilateral shared world, there will be a crisis if there is no form of equity in how the vaccine is distributed across board. This is one of the reasons why COVAX was created, and it had a plan to distribute 330 million COVID-19 vaccines to developing nations in the first year of 2021. Nigeria, country where I'm from, is expected to receive 60 million vaccines before the end of June. And African Union has also secured an additional 400 million doses from China, Russia, and I think there's a lot of conversation also with Johnson & Johnson, which is the newest cohort in the vaccine development phase. But there are still issues around equity right at the multilateral level, and also equity downwards, even when we see it when it comes down at the national level. In Nigeria, we are inundated with questions and conversations about people who have no reason to get a vaccine. So I'm in the US right now. I'm not yet vaccinated just because I still don't meet the age gap to be vaccinated. I mean, there's a phase to it. But this is not the situation I see in Nigeria and also in other developing countries where institutions can be grossly weak, and that people jump the queue, people have turned the vaccine to some form of privilege, and also which is also now deepening hesitancy around the vaccine itself. So I I'm happy that we're having the majority calling from Nigeria. So I will bring on Marlise on board. She's the expert that will delve more into this conversation as we go along today. And I believe that she will do enough justice to the work that we're also trying to do. One of the questions that we want to know is to look into, and I will do a bit of intro, is to look at the issues and challenges around the way governments in African context are making decisions about who gets priority access. It might be written on paper, but it looks like the implementation is weak. We also want to explore the unequal relationship between the global north and global south on vaccines access and equity. We want to know what are the opportunities for improving equitable access to vaccine rollout. We want to define what exactly is the concept of equity when we talk about vaccine access in Africa. What exactly does that mean? And what are the communities that are disadvantaged or advantaged in the context in Africa? And how do we address those imbalances? And I think finally, we're also trying to interrogate in this session, how can CSOs meaningfully address some of the issues around vaccine equity using transparency and accountability mechanisms? I will stop there and do a bit of introduction on Marlise. So our incredible researcher. So Marlise has worked for over 20 years in the health and human rights field, and has served in several South African NGOs and civil society organizations. She was also a researcher at the project Literacy, the AIDS Law Project, the Treatment Action Campaign, Reproductive Health and HIV Research Institute unit, and more recently served as the head of policy development advocacy at Sonke Gender Justice. She holds a BA honors and LLM degree from the Wits University, South Africa, and completed an MA in International Peace Studies from the University of Notre Dame, US, as a Fulbright scholar. That's incredible stuff. In 2013, she graduated with a PhD in public health from the International Center for Reproductive Health at the University of Ghent, Belgium, on sex worker access to healthcare services in sub-Saharan Africa. She has published in academic and popular forums in the area of law, bioethics, gender, migration, and public health. She holds a visiting researcher position at the Africa Center for Migration and Society at Wits University, and currently focuses on research, advocacy, and policy change in gender, human rights, and COVID-19 pandemic, with an emphasis on impact on criminal law on health access for sex workers. So you might hear a bit of how the sex workers even adapt in this environment. Please welcome Marlise Richter. I wish there could be some drum roll feature on Zoom, but there is none at the moment that I know of. But we are glad to have you, Marlise. Thank you.
Thanks, Oluseun. I've never heard the drum roll on Zoom. Good afternoon or good morning or good evening to our participants. It's really nice to see such a cross-section of countries represented. It's a privilege for me to be speaking this afternoon. And I've prepared a PowerPoint, which I'll ask if Isabel could please share her screen. I'm currently working at the Health Justice Initiative, and I'm a researcher there, and our organization has worked in issues of health equity. I'm just going to wait for the PowerPoint to come on, and then I'll show some slides about some of the work that we've been involved in. Thanks, Isabella. Excellent. Could you please do the next slide? So the Health Justice Initiative is an NGO that was established in July 2020 in South Africa. We are a dedicated public health and law initiative that addresses the intersection between racial and gender inequality. And we have a special focus on access to life-saving diagnostics, treatment, and vaccines for COVID-19, TB, and HIV. And we use the lens of health equity in the issues that we address. Next slide, please, Isabella. Today, I'm going to talk a little bit about COVID-19 vaccines and who's getting them and what some of the barriers and enablers are to ensuring that everyone in the world has vaccines and that we can achieve herd immunity. So I'm going to show a couple of pretty graphs and maps just to show you what useful data is out there that is constantly updated. The vaccine sector and those working in it constantly change. The data is currently being updated, and some of these sites you will note that I include the data when I had extracted the data. So the Bloomberg vaccine tracker talks about the vaccine project as one of the biggest vaccination campaigns in history. And if we look a little bit at the data, as of 2 days ago, we've had more than 546 billion doses of vaccine that had been administered across 141 countries. It sounds like a lot, but it's only enough at the moment to vaccinate 3.6% of the global population, which is really little. That averages out at about 14.5 million doses a day. The US is quite close to achieving herd immunity. They are vaccinating close to 3 million doses per day. And if they continue at this pace, it will take another 4 months before they probably reach herd immunity. Can I have the next slide, please, Isabella? This is a map that I've taken from the vaccine tracker. And you will note that the dark green gives you an indication of the countries that have more than 20% of their population vaccinated. You'll see that the US is in dark green, the UK, many of the European countries, some South American countries, and then in Africa, we have Morocco right at the top that has a very good vaccination rate. Isabella, the next slide, please. To focus a little bit in on the data of the vaccines. I note here that the data that I'm using is from the Conversation Africa, that has a really useful vaccine tracker together with MediaHack. This is an overview of Africa and some of the countries that have started vaccinating. And in the next couple of slides, I'm going to show you a breakdown of some of the countries. And I'm going to go through it quite quickly, but just for people to get a sense of where the different countries are at. Isabella, if I can have the next slide, please. This is some of the countries in alphabetical order. You can see a couple of countries you'll note has no data available. Here we have Botswana, Congo, and Cape Verde and Djibouti. Algeria with 75,000, and then Egypt with as little as just over 1,000. Next slide, please, Isabella. Again, a couple of countries with no data. You can note that Morocco is far ahead of the pack with close to 8 million total vaccinations. And what's useful about this breakdown is that it also gives you the countries and what pharmaceutical company is providing them with vaccines. Next slide, please, Isabella. We have South Africa with just over 240,000, Namibia with 152 altogether. And then the last slide, Isabella. Uganda, Tunisia, and Togo with a range there from 40 to 70,000. Next slide, please, Isabella. So this data is quite useful. MediaHack has calculated taking the vaccination rate of specifically South Africa and gives us a sense of how many vaccinations is happening per day. And using this rate, they estimate that it will take another 15 years, almost 16 years, for South Africa to vaccinate 2/3 of our population. If you look at some of the previous data that I've shown, you can imagine that this might take much longer for some of the other African countries, especially those who haven't even started to vaccinate yet. Next slide, please. This brings me to the issue of vaccine equity, and I'm going to ask that we spend a little bit of time on this slide just to figure out all the colors and the shapes. You will note This comes from The Guardian, and they use a really useful website that I would flag, the Duke Global Health Innovation Center. This is data from the end of January, so it's not that up to date, but it still gives us a useful sense of vaccine equity. So the different colors show us where the vaccines are coming from, what pharmaceutical companies, and the black square shows us the population of the different countries or blocks, and in relation to the total doses of vaccine that they have bought. You can see in the European Union, if you're a citizen there, you have 3.5 doses per person. This goes up to Canada, where they almost have 10 times as many doses than what is needed for their population. If you look at the African Union, you can see that we only have 0.2 doses per person. So next slide. I think this graphically shows us the huge disparities between the global north and the global south. And this disparity was articulated by the World Health Organization Director General in January as talking about the world being on the brink of catastrophic moral failure. And he speaks about the price of this failure will be paid with the lives and livelihoods of the world's poorest countries. So of course, if we want to reach global herd immunity, vaccine equity is key. And vaccine equity is essentially about the equitable distribution of vaccines worldwide, not just within a country, which is often termed vaccine nationalism. And we've seen vaccine nationalism at a great scale in some of the previous maps that I've shown you. Can I have the next slide, please? So vaccine equity is given a little bit more detail in the World Health Organization guidance on fair allocation. And this applies directly to the COVAX facility that I will speak about next. And the World Health Organization advises that as soon as a vaccine is shown to be safe and effective and authorized for use, all countries should receive doses in proportion to their population size. And this will enable every country to start by immunizing the highest priority populations. And then once the highest priority populations have been vaccinated, vaccines would continue to be deployed to all countries so that additional populations can be covered according to their national priorities. So a very clear prioritization of specific groups that are at most risk, and then only to move to the general population. Next slide, please. So I'm going to speak a little bit about two main mechanisms in which vaccine negotiations are taking place. The one is COVAX, and COVAX is a global collaboration that draws on collective buying power. And it's coordinated by Gavi, the Vaccine Alliances, the Coalition for Epidemic Preparedness, and the World Health Organization. And it's basically a platform that will support the research, development, and manufacturing of a number of vaccine candidates and to negotiate their pricing. Its principles are around all participating countries being able to have equal access to vaccines once they've developed, regardless of what that country's income level is. So the COVAX initiative is aiming to have at least 2 billion doses available at the end of 2021. And they foresee that this would be enough to protect high-risk and vulnerable people, as well as frontline healthcare workers all over the world. So being clear that the most vulnerable populations all over the world should be vaccinated first through the COVAX principles. Next slide, please. The next mechanism that I think is important to know of in the African context is AVATT, and it stands for the African Vaccine Acquisition Task Team that forms part of the African Vaccine Strategy. It was established by the African Union in November, and it started operating in around about January. And it's similar to COVAX, and it helps secure vaccines for member states of the African Union. So once again, negotiating on behalf of a number of countries increases their negotiation power in relation to pharmaceutical companies. The next slide, please. So this afternoon, our focus is accountability and transparency. And COVAX and AVATT raises a number of questions for us as civil society members and activists who care about access to information. We feel strongly that civil society should leverage pressure to keep COVAX and AVATT accountable and to push for greater transparency, which I don't think is present at the moment. There's a number of concerns with COVAX, and I'm just going to briefly mention them, and I'm hoping that there are participants in the seminar who might be able to speak about them in more detail. There's been some concerns about COVAX's ability to enter into agreements with pharmaceutical companies. COVAX has been able to purchase 1.1 billion doses of vaccine, probably a bit more by now, compared to about 4.6 billion doses that have been secured by high-income countries. So that negotiating and purchasing power is not as strongly influential as people had hoped when COVAX was established. Key to the weaknesses of COVAX, we would argue, is that it fails to address intellectual property rights. And some critics of COVAX see COVAX as an excuse to discuss and critically engage about intellectual property rights and the skewed balance of power in pharmaceutical countries and the grip that they have on global health. So Sophie Harmon, a professor of public health, speaks about, if your problem is you want to have affordable vaccines around the world to cover the majority of the world, then the solution lies in free licensing and compulsory licensing. So you're challenging the framework around intellectual property. COVAX doesn't do that. It works within that system. Importantly also is the lack of transparency in COVAX's negotiation and contracts with pharmaceutical companies. And this is very much at the behest of pharmaceutical companies. They enforce, and I'm going to ask for the next slide, they enforce non-disclosure agreements with the people and the individual countries, as well as the block negotiations that are taking place. We haven't seen the agreements of COVAX and AVATT, and we feel strongly that they should be disclosed. So we basically subject to multinational corporations' non-disclosure agreements. It means that we as civil society have no transparency on the price and the no-fault schemes that pharmaceutical companies often enforce. And this is an issue for the whole of the African continent. COVAX also has some penalties. There's only a certain number of vaccines that are currently being used. And then some of the other questions that we need to ask is, how is AVATT going to allocate vaccines to different countries? The African Union has an allocation framework based on health prioritization, but will this prevent queue jumping, as Oluseun has referred to a bit earlier? We will still need to see how that plays out. Next slide, please. Yesterday, it was announced that Johnson & Johnson and the African Union has tied up a deal of about 400 million COVID-19 shots. This is great news. It will only start in the third quarter, and most of the vaccines will come towards early 2022, or at least in 2022. And that again raises issues of health equity. If these vaccines come so late, what that means for countries who have reached herd immunity long before some African countries might even have started their vaccinations. And once again, we don't have enough information about this agreement and the details of it that we feel is absolutely necessary in civil society insistence on accountability and transparency. Next slide, please. In the last section of my presentation, I'm going to just speak briefly about the work that the Health Justice Initiative has been involved in to challenge excessive pricing and also to demand transparency and information in terms of the South African rollout. And I'm looking forward to hearing from examples from our audience about how they have used domestic and international law to encourage accountability and transparency. Next slide, please, Isabella. So in the first three examples of the Health Justice Initiative, we've used some of the laws and independent bodies that have been set up by South African law to challenge the private sector. Our first example comes on the pricing of COVID-19 vaccines. We joined up with a health organization where we referred a matter to our South African Competition Commission on the price of generic versions of dexamethasone and remdesivir, medications that assist with the treatment of COVID-19 and particularly with hospitalized patients. Drawing the attention of the Competition Commission to some of the pricing of the generics that would increase access to these important medications. Once again, excessive pricing by the private sector. We joined as a friend of the court with the South African Competition Appeal Court, together with another South African NGO called Open Secrets, where we brought additional arguments around excessive pricing. So Babaleki Workwear and Industrial Supplies, the company was found guilty of excessive pricing of face masks by the Competition Commission in 2020. And they appealed this decision. So we brought in additional arguments to show the importance of the impact of excessive pricing. The appeal was dismissed and Babaleki was fined. And we believe that the jurisprudence from this case will have an impact on the pricing of essential health products in the private sector. So it's not just for COVID, but also beyond COVID, what that means in terms of pricing and accessibility of essential medicines. Next slide, please. The last two examples I want to mention is a more recent case that pertained to parallel procurement. We once again joined as a friend of the court in a case where a South African trade union and an NGO took the South African government to court because they wanted to compel the government to allow the private sector, NGOs and provinces like provincial health departments to procure and distribute vaccines independent of government. We brought arguments to show that it's in the interest of health equity to have a central procurement mechanism. And these two parties withdrew their case in earlier this month, which we rejoiced, and we were able to generate debate and encourage people to think very much about the importance of health equity. And in South Africa, we've got a very unequal healthcare system, and what that would mean if the private sector was able to vaccinate large parts of their members, for example, and with the public sector lagging behind, and how important it was for a central mechanism in the context of severe scarcity of vaccine supplies, how important it is to have a central procurement mechanism. We've had ongoing engagements with the South African government on requests for information about the details around the development plan to ensure affordable access and equitable allocations of the vaccine. And this engagement has lasted many months, many letters sent to the Minister of Health, including a letter of demand, and where we've been able to extract some information, but not as much as we need to be able to hold the South African government to account about their approach to procurement, as well as how the vaccines will be allocated and how the details of rolling out this massive task of getting vaccines to everyone who needs it. Thanks, Isabella. My second last slide is some of our advocacy asks as the Health Justice Initiative, together with international organizations, activist organizations, around intellectual property and making vaccines and other essential medicines more accessible. We believe that we need to share technology, that pharmaceutical companies need to make their recipes for vaccines accessible, and that vaccines should be seen as a global public good. And these are the arguments of some of the international campaigns, and I'm going to mention specifically the People's Vaccine Campaign. That's an international campaign. We have a chapter or a South African version, and also the Free the Vaccine Initiative that makes many of the same arguments about making vaccines accessible to everyone. We very much involved around pushing for an equitable plan for access and allocation in South Africa. I've mentioned our severely unequal health system, and how we are pushing for a one country, one plan. Doesn't matter if you have medical aid, if you're dependent on the public sector, you shouldn't be able to access a vaccine before the equitable allocation has happened and the priority groups that we've spoken about have been able to access. There's often, no, today I haven't really been able to speak about the TRIPS waiver, but it's an important international mechanism with the World Trade Organization that will make vaccines more accessible. And it is regrettable that the countries who have been able to vaccinate have enough doses, as you can see from that colorful block Guardian infographic that I showed. The countries in the global north who can vaccinate or have enough doses to vaccinate their populations many times over are also the countries that are blocking the TRIPS waiver that would make that will loosen the intellectual property framework for the duration of the pandemic and would make COVID vaccines and other related medicines more accessible, and particularly for lower and middle income countries. But the TRIPS waiver is being blocked by many of these countries in the global north, and it's an ongoing engagement and debate that's playing out at the World Trade Organization that requires strong civil society action and pressure. Again, the issue of transparency. We need to have drug companies, corporations, and even university research institutes to open their books to us, to show the public all the research and development and production costs, so that we can be clear that the prices that are being charged will not lead to excessive profiteering, and that will make these products available. Of course, companies cannot unilaterally decide supplies or pricing, or even when the pandemic ends, where some pharmaceutical companies have decided that they will tell us when the pandemic ends, and when they will reduce their prices or increase them. And then lastly, the absolute key about community involvement. We need to encourage democratic participation to build community trust, and especially avoid vaccine hesitancy, and challenge the growing anti-vaccine movement. My last slide, please, Isabella. This is a couple of references and reading materials. I want to thank my colleague Fatima Hassan, on whose knowledge and slides I have drawn, and to note some of these articles and reports that, together with some of the references earlier from the sources that I've drawn on, would provide more information on some of the issues that I've raised. Thank you very much.
Thank you so much, Marlise. That's an incredible one, and I'm glad you're taking a cup of water to relax a bit. Yeah, so we'll take questions and answers. Yeah, and maybe I would just want to start from the from my team, also from Zikwizo. We have Zikwizo Kotaye, who's a member. She's a member of the alliance that powers this. And a question: are you seeing any trends or correlations between progress in various vaccine rollouts by Supreme Audit institutions or parliamentary committees? Is there any trend around? Because we know that in spaces where there's corruption, where public institutions are weak, there's always a huge tendency for people to abuse that kind of environment. But do you notice if there is any, we've seen that a bit with the COVID-19 related funds, or do we see any involvement of the audit institutions or parliamentary committees at this level? Yeah.
Thanks, Zuki and Oluseun. And this is really a question I agree I would very much like to hear from other people on this call. I've seen specifically in some of the international advocacy around pushing for a people's vaccine and for challenging intellectual property rights, that there's a strong civil society push around accountability and around transparency. I think Zuki is absolutely right that parliamentary committees need to provide oversight. In the South African context specifically, our Speaker of Parliament should have a copy of the agreements that our government has made with pharmaceutical companies. It's public money that's being used to buy vaccines. In other instances, public money needs to be accounted for and there needs to be transparency, but yet there seems to be this exception when dealing with pharmaceutical companies. And I think there's other countries where civil society members are lodging freedom of information challenges to pharmaceutical companies to disclose some of the components of the non-disclosure agreements, and where civil society organizations are pushing back against the power of the pharmaceutical industry. I think that there is a greater need for some of the accountability and the transparency NGOs to come together and to forge a collective plan of action on the type of questions. And I think there's members here from Transparency International, some really useful questions that civil society members can ask of their leaders and of their government, and that there is a strengthening of different sectors within civil society, different countries who can come together to push more collectively on transparency and accountability. So I can't comment in detail about trends, but I have definitely seen activists become more passionate, and especially some of the HIV/AIDS activists who had been speaking a lot about intellectual property and some of the lessons that we've learned, being able to draw on those resources and being able to leverage networks and partnerships that were so important during the AIDS epidemic, and to use those again to challenge some of the international, the transnational corporations. And I'm hoping much more of that will happen.
Great. I mean, so there's just a question here. Maybe I'll just put it together. The one from Gabriel Kewo and from Ian Fatoba. And it talks about vaccine production in Africa itself. You know, there's a lot of conversation around equity, but it looks like we are even starting 10 yards behind, even maybe 10 miles behind. It's still been a push around vaccine production in Africa. Is there anything around there, like research institutes leading this kind of efforts in Africa? Because we've seen production in India in significant way to be able to meet this gap. Is there anything happening within the African front?
Is that a question specifically to me?
Yeah, to you.
Okay.
Yeah.
So I'll be honest, I don't have that much knowledge about manufacturing, and I'm hoping that there would be someone else on in the symposium who could speak to that. What I do know is that there's a lot of unjustified Afro-pessimism about vaccine manufacturing, and that there is definitely capacity to do so, but there needs to be more investment in it. And that there are some countries and organizations who are pushing for greater investment. It goes the same for arguments about the health system, about how the health system needs to be strengthened and how Africa needs to have its own manufacturing, because COVID-19 is not going to be our last global pandemic, and that as civil society, the private sector and the public sector, we need to push for more investment and political will around manufacturing. I think there's a lot of false arguments about Africa not being able to produce vaccines, and I think those need to be challenged.
All right. I mean, so I'm happy that you talked about the pessimism itself. I mean, last one, before I ask my own question, there's a question here from Yanu Fatoba also, which is talking around the conversation you had on the trip. The conversation you had on the trip itself. Maybe you want to expand a little bit more on that. Then also, what do you think are the lessons that we can learn? I mean, I think you've answered a bit of that around the behavior of the developed countries and the private sector in the handling of research, development, and distribution of vaccines. Yeah.
Excellent. So with the TRIPS waiver, perhaps just to say a few words about that. I think it was in July where South Africa and India sponsored a proposal to the World Trade Organization, requesting basically that some of the intellectual property provisions that have been accepted by most countries in the world, that there's a waiver around the implementation of the safeguarding of intellectual property around vaccines and health products with COVID. And it's a very time-bound waiver. It's specifically for the COVID pandemic, and it will require that the World Trade Organization and its decision-making is by consensus, that countries come to a consensus that some of these very stringent intellectual property rights will be waived, and that more that the recipes for vaccines and for other health products would be shared, and that there would be opening up of some of the knowledge and technical knowledge, and that those are shared amongst countries. Overwhelmingly number, more than 100 developed, more than 100 lower and middle income countries, including the African Union, have strongly supported the TRIPS waiver. A couple, not many of so-called higher income countries have supported it, and significantly, and I really want to emphasize this, the countries who have access and who have pharmaceutical companies within their countries that are leveraging great political pressure on their governments, the countries who have enough vaccines to vaccinate their populations many times over are the ones who are blocking it. And significantly, it's the United Kingdom, it's the USA, it's Australia, it's also Brazil, which is an unusual phenomena, breaking with its BRICS partners. And some of the work that especially Doctors Without Borders, MSF, has done around the Access campaign is to challenge the countries who are blocking the waiver. And that is something that we need much more international pressure and solidarity about. The World Trade Organization is still in discussions about it. And as global pressure mounts, we see that there might be some wavering by the US, or there's some hopeful developments that will open up some of the IP discussions more, and that absolutely requires that we need to leverage pressure through those mechanisms. Just looking at the other questions.
I think I have my own question.
Please.
Maybe I didn't type that, but I wanted to take you on the issue of, you spoke about COVAX and the AVATT. I don't know if that's the way it's been pronounced. You spoke around that we have not seen the agreement. There seems to be a bit of lack of transparency on board and in how that work is going. My question is, what can civil society do I mean, maybe this is also time for us to talk about multilateralism from the civil society and too.
Yeah.
What can civil society do to be able to push that we need a bit more transparency around the issue of vaccines? I mean, in Nigeria, we're still looking at 16 million has been promised by COVAX, but this will not even reach. It's like 20% of the population itself. I mean, if we take the adult population alone, in Nigeria. So, I mean, that's not even enough to even go around. So what would you think would be a way forward for civil society to be able to intervene on issues of transparency and accountability?
And that's a very important question. And I think specifically being able to keep track on a country level how much COVID, perhaps let me premise the remarks by saying the COVAX facility has a forecast. It's got a quarterly forecast in which it talks about how many vaccines have been allocated, or how many are available, where they're going to be allocated. And civil society needs to keep a very beady eye on those forecasts and to tally the vaccines there with what their countries are saying, and to track where those vaccines, whether those vaccines are coming to countries. We worry a bit about double counting, and to keep an eye on the amount and the number of vaccines promised and the ones that eventually land up in your country, and ultimately vaccines going into arms, right? Because that's what we want. We want vaccines going into arms. So civil society has a complex and important role to play, because that information is available, but it often has to be tracked through press releases and what governments are saying. Is it through a PowerPoint? Is it through a tweet? Is it in an official government document? And to keep governments to account about their promises around vaccines, and the COVAX facility and AVATT specifically. I think there's a number of, the African CDC, and it's a pity that they're not here this afternoon, because I think it would really be important to hear from them about AVATT and how they are keeping AVATT accountable. And I think there's a number of peer review, a number of review mechanisms that are available through the African Union that many of the people on this symposium are probably working in already or are using. And we need to be asking questions about AVATT in terms of information. Like, it's hard to understand, to wrap your head even around AVATT. I can't find a website that contains information with AVATT saying this is what AVATT's about, this is the decisions that have been taken. You have to look at speeches. President Cyril Ramaphosa's speech that he made in January to find out what AVATT was doing at that point. So we need more information. We need information that's accessible to civil society, and of course include the role of civil society. So we need to demand that we have a place at the table to make some of the decisions about vaccine allocation, and that we need to keep the board of these mechanisms to account. And pressurize them to release information and to deal with civil society and to keep the pressure up in that way.
Okay, all right. We will take that in and move forward. I will just take two questions from Reunkum. One comment is coming from Judge Jobe, is calling us from Malawi. He's joining us from Malawi. He says, to ensure that most people get vaccinated, is need to for work around community sensitization and awareness raising, especially in rural and hard-to-reach areas, will lead to limited impact access to information. And I think that's a very key part. And for equity, also we have to step up communication and information to the most vulnerable groups, so that they also be able to come on board on this whole situation. Ray Nkum is talking about COVAX has informed recipient countries that there will be delays for delivery of vaccines for AstraZeneca in March and April. Do these delays significantly delay the vaccination process? Since some people have taken their first dose, I don't know. People have taken their first dose, they might not get their first dose in time. Does it reduce the efficacy of the entire vaccine itself? I mean, this is not an equity question. This is more like a vaccine expert question. But do you have anything to say about that? Yeah.
Thank you for George from Malawi. I think, George, you raise a really important point about the division between rural and urban. We've seen in South Africa with the fact that close to 300,000 of our healthcare workers have been vaccinated, but they're mostly in urban areas. And that raises alarms for the millions of other people that need to be vaccinated in South Africa, those in the rural areas, and what type of mechanisms exist for those vaccines to reach people in rural areas. And I hear you saying the same in Malawi, and I suspect this is probably true for the whole of Africa. And I'm wondering what type of lessons we might be able to get from Morocco about the number of vaccinations that they've been able to do, and how they've dealt with specifically getting vaccinations to rural areas, especially those vaccines that require very cold temperatures. I haven't really considered the delay of AstraZeneca and the delays around that. I think there is an optimal time to get your booster vaccine. And the ideal time, I think, is about a month or 6 weeks after your first shot. I don't think it is probably such a calamity if it's a bit later, that it will probably still be effective. It's just worrying that that date will be pushed back. But I think a medical doctor or a vaccinologist will be able to speak to that in more detail.
More detail. All right. I think we take that as a cap. I will just use the last sessions to, I will read through the questions, but we might not be able to answer them. So I'll read those questions. The efforts, the way about Johnson & Johnson vaccine, who's paying for that? Is it going to Africa alone? I think I answered that. The Johnson & Johnson vaccine is, it's a different conversation apart from COVAX. The African countries are also entering direct agreements with international manufacturers to get access to vaccine. And I think that's part of the Johnson & Johnson, because like we've agreed, COVAX will not be enough for most of these countries. And so definitely there are countries that will have to also procure privately from all of the US manufacturers. Number two, while there are efforts to develop global framework for defining equity, what counts an equitable outcome will vary depending on local epidemiological evidence, but also on contextual social vulnerabilities. This comes from real-life contextual evidence. Aside from international vaccine allocation, what type of evidence needed to fully define equitable outcomes, improve targeting, and measure the effectiveness in delivering equity? Just one line, which will be my last question to you. If we're going to say in a sentence or two, what would equity, I'm not talking about equity at the global level, what would equity mean for you in communities, in environments, within African countries? What would be a catchphrase that we have to go back with when we think about equity within the spaces? Yeah.
I think Marco's question is a very good one, and it comes to our definitions around vaccine equity. The World Health Organization has developed some guidance through the SAGE principles. In Africa, we have used the SAGE principles to come up with an equity framework. And we've used some of the principles of the WHO, and we've inserted Ubuntu in it to talk specifically about African values and the material realities of our continent. It also means that countries need to engage with vaccine equity. Every country is different. I think there's a lot of similar vulnerabilities across our continent, but it manifests in different ways in different countries. And it's absolutely vital to have civil society participation in how vaccine equity is debated and discussed, and it's a very hot topic, and it requires the voices of particularly marginalized groups. And this is where I'll speak a little bit about sex workers, because we've been involved in thinking around how will sex workers access vaccines in South Africa. The questions about how sex workers are seen as vulnerable populations. They're not regarded as workers, and they've fallen out of some of the safety nets that have been provided. And what does that mean in terms of being able to access the vaccine in an environment where many sex workers don't feel safe within the healthcare system because of discrimination that they've experienced? So those are the type of voices that need to feed into a decision-making body about what equity would look like. And equity in South Africa might look very different to what equity might look like in Botswana, for example. So I think Marco's remark is an important one, where we use definitions that are useful, but that we contextualize it. Listen, I'm sorry, I forgot the other question.
So no, I don't think there's any other question. Again, I was talking about the. Yeah, I think that would sort it out at this point.
Is it?
Yeah.
Okay.
All right. So I think thank you so much. It's a great it's been a great session, and I really want to thank you, Marlise, for the great conversation we've had here on the issue of equity, on the issue of vaccine equity deficit specifically, and we've put that into the African context. I like your fastener question. We need to even localize the definition of equity. Wherever we're trying to even build, we must know it's about putting the most vulnerable, the most marginalized, the most challenged, and putting people first. I mean, there's a whole lot around this role modeling of vaccine distribution that has become a folder for inequity. People saying the government people should get it first, or the traditional rulers should get it first, to model people within the environment to get it more. But some of that has become also a passage for where do you draw the line, and who gets and who doesn't get. And that's why equity is incredible. I'm also like your response about the civil society, how that's extremely important. That society needs to bond together. We need to work together to be able to use these times to build conversation on vaccine equity. I also like how we need to do more work to demand transparency from COVAX and from the AVATT that is headed by President Cyril Ramaphosa and the rest of the group. I believe that we've all taken a lot away from here, and I find this very, very useful. And we'll all continue this account for COVID series, and we'll come back again on vaccine. Maybe next time we'll talk about misinformation. We'll talk about also also how do we reduce vaccine hesitancy. But I even think before we talk about vaccine hesitancy, we even have to have enough vaccines to be certain that people are even hesitant to take them. But we need to prioritize equity at this point. I also want to talk about CTAP. So we have the account for COVID going, and also in collaboration with the CTAP program, which is a project handled by Budget, Global Integrity, and Connected Development, and we are working towards transparent accountability on the management of COVID-19 in Africa. We should have our major grant launch in April 27, and we're working effectively towards that. One of the key things we're trying to do is to be able to curate data around resources that have been distributed for COVID-19 in Africa. Also do a bit of learning across partners. This is one of the things we're doing to ensure that there's mutual learning across partners on issues, on contextual issues related to COVID-19 itself. So, I mean, that's just going to be all from my hand. And I want to thank you, Kai. I want to thank Isabella. I want to thank Sikizwa. I want to thank Judge, Gabriel, everyone who has worked in the background to make this a great session. And I want to also thank you specifically, Marlise. Thank you so much for the time you spent here. Once again, we apologize for not having the DG for NCDC here at this event. It was for situations beyond our control. So have a great time, guys, and hope to see you some other time. Thank you.